Welcome to the 2020 Public Health Law Virtual Summit. We have two presentations in this session, and each presentation will be followed by a Q&A. Use the chat feature to submit your question. If you encounter technical difficulties, go to the navigation menu and select Need Help. Now, I'll turn it over to our first speaker.
Well, good afternoon. I hope everyone can hear and see me. If for any reason if I'm not coming out clear, then please send a chat to our organizer, Kayleen. It's great to be here. I'm so proud to be part of this COVID policy playbook project. The panel I'll be speaking on today is safety for care facilities and essential workers. I'm a big fan of Rakea's work as well, and she'll be joining us in the second half of this panel. I'll be specifically talking about quality and safety in long-term care. And I'll go ahead and get started. So in my chapter, as part of the COVID policy playbook, I included it here on the side, and I believe you'll have access to my slides after this presentation, and I just want to give you a heads up that all of the images are already hyperlinked to websites, so you'll be able to really treat it like an interactive PowerPoint and can just click on different images to get directly to materials that you might want to read for more information or more background. So what I'll be talking about today is all covered in the chapter, but then there have been some pretty sweeping announcements just this week in this area. So I want to touch on those as well. And I thought it'd be a great opportunity to dig a little deeper into some specific state experiences with quality and safety in long-term care and how their oversight issues and enforcement. So I'm going to focus on Indiana and New York and provide some recommendations, both from me, and then I also pulled some from industry, which I think will be interesting to note. And then really related to that, how this is an industry with some long-standing issues, and in many ways, COVID-19 shows how ripe it is for disruption. So these are some of the long-standing issues that I highlight in the chapter, and I basically refer to it as three major missteps, and that involves staffing, infectious disease controls and prevention, and then emergency planning and accountability. They all, in some ways, interconnect with one another. So staffing is no real surprise. That's been in the headlines so much, just how inadequate the levels are. Some studies say that as many as half of the nursing homes in the country don't have the adequate staffing levels to provide basic standard of care, to meet basic standard of care needs. And that was from a CMS perspective. So related to the inadequate levels, when you have staffing that's so thin, it becomes a much more stressful job than it may be otherwise, plus the wages are quite low, as I'll get into, and that leads to very, very high turnover, as much as 30% in some areas of the country. And then the benefits, which I know Rakea plans to touch on, and also note in my article, and where I'm really discussing, especially during a pandemic, are issues related to paid sick leave and access to healthcare. So as you can imagine, when you have a really thin staff, it's much harder to control for infectious disease. And this is even before COVID, where according to a very well circulated now Government Accountability Office report, over 80% of nursing homes in the country had received some type of violation over the last few years, pre-COVID. And then related to that, just last year, the CDC said they can account for over 380,000 deaths directly related to an infection. So clearly these are all things that happened pre-COVID, that when COVID hit, these facilities were just in a very disadvantaged place to manage an extremely infectious disease that can circulate through the air as easily as COVID does. The last part really is just remarkable to me on emergency planning and accountability. And that's why I really talk about the New York experience. But there's been a phrase going around, which is saving hospitals with nursing homes. And you can see that quite a bit with some of the competition for resources, particularly with PPE and testing. And also just the overall limited oversight when it comes to nursing homes. I almost refer to it as an inverted triangle, where you have a lot of tens of thousands of inspections are happening. And of that, there's probably thousands of citations, and then maybe hundreds of fines. And that if like a small number of facilities that are extremely poor performing may be closed. So there's not really a direct correlation between how a repetitive citation and then what that could mean for a facility in terms of how they respond to it. And some of that also relates to the data. A lot of the data is self-reported, and there's been a lot of criticism regarding the CMS ranking system, the 5-star system, and that it's not necessarily predicting some nursing homes that are having the outbreaks versus those that aren't, and how to make it much more reliable, transparent, and meaningful data to really target resources. So in a broad but succinct nutshell, those are the 3 areas and the underlying issues that I touched on in the chapter. So now what's coming out more and more, the New York Times does a tremendous job of covering, along with the Washington Post and many other Wall Street Journal well-read periodicals, but just the enormous amount of deaths, and then often what's not included, but the suffering and harm that's happening to nursing home residents and the workers who care for them. So what is the size and scope of the problem? Well, essentially, to give you some keep in perspective what this is, so there's about 1.4 million people that are residents within thousands of these types of facilities and communities. So that roughly is 1% of the US population. However, and this number keeps increasing, but currently this 1% of the population is linked to 40% of the COVID-19 related deaths. So an extremely disproportionate number in terms of if there is an infection, it often leads to death in these types of very medically fragile groups of people. The other point I want to highlight about this area is how the majority of staff that work in these types of facilities are what they call certified nursing aides, and they earn low wages, anywhere annually between $15,000 to $20,000 a year. So as a result, it's actually fairly common. About a fifth of these workers end up working in multiple long-term care facilities. That's what I referred to earlier on, not just me, but many people are referring to this group of people who are working in multiple facilities to make ends meet, or because their jobs may not be that secure as these super spreaders. And they do tend to be low-income female immigrant women. So I thought this quote from a Latina woman would be helpful to share with you. I thought it summed up very nicely the challenges that she faces. And she says, we have to go to work, we have to pay our rent, we have to pay our utilities, we have to keep working. And when you're in a job where the staffing is already so thin that there isn't a safety net to not go to work, that could also harm residents and their care. And there's limited benefits in terms of paid sick leave. Have to keep earning a paycheck to pay the rent, and then related to that, even to receive care if they did suffer really severe conditions from a COVID infection. So what I also think is remarkable is the counterpart to this, and this is from a New Jersey health commissioner, but it's not a unique statement from across the country, where it's just such a stick approach as opposed to a carrot. We're basically assuming that the only option is to say, oh, we can't tell nursing aides that they can only work at one organization because we know the wages are not enough. And this part I thought was the quote I put in bold as well, where they're working their little hearts to the bone just trying to survive. And I just thought, how horrible is that assessment of the situation when you know that there are avenues that could take place that would not put a vulnerable worker in that situation in terms of offering paid sick leave or increasing the wages, so there wasn't this need to work at multiple facilities. So what this also is a fascinating and troubling parallel to is the story of Mary Malone, which is commonly known as Typhoid Mary. And my co-author at University of Arizona College of Law and I are now writing about this. We're calling for the return of Typhoid Mary, immigrant workers in nursing homes. Because there's just incredible parallels between what's happening now and what happened at the turn of the century. Just a quick note on who Mary Malone is. She was basically an Irish immigrant who came to America as a cook. Turned out she was a healthy carrier for typhoid and did end up infecting and causing about three deaths. She was quarantined for the last 23 years of her life in an island north of New York. There were other healthy carriers at the time, and none of them experienced the same punishment that Mary did for her actions. And I think what it all comes down to is she was a cook by trade and had limited options of what else to do. And what we're doing with my co-author and I, she runs the worker rights clinic over at University of Arizona. And she actually was confronted by someone in a similar situation, but now during COVID. And we're just call her Selma. And but basically, where she's in a situation where working very, very long hours for very little pay, and no access to paid sick leave, and then a great deal of fear in terms of even accessing those benefits due to potential retaliation from the employer, and specifically for someone in a situation of immigration enforcement, where there are about 16 million Americans who live with an undocumented person in their household. So even if this this person who we de-identified was perfectly legal and able to work herself, she could have fear for other people in her household. So, so you can see just a lack of ability to access rights that she would otherwise be entitled to. I think this all comes down to, if you compare these two stories of low-income immigrant women working in these really difficult jobs, who end up getting infected by infectious diseases, the focus, unfortunately, tends to be against the individual rather than the conditions in which they find themselves forced to work in. So the two state experiences I just wanted to address during this time, which I don't touch at all in the chapter, is what's happening right now in Indiana, because it's been quite fascinating, especially given this week's announcement from the CMS. So essentially, this is an argument I do make in the chapter, when funds are not tied to quality or staffing metrics. So Indiana does have one of the higher end percentages in terms of the number of deaths related to COVID in nursing homes in the state, around 60% compared to the national average of 40%. But yet they received a great deal of Medicaid funding, in fact, more than any other state. However, they rank near the very bottom when it comes to staffing. And it turns out, due to some pretty amazing reporting by Emily Hopkins from the Indy Star, this is something you want to follow, that the vast majority of those funds that were meant to be reserved for specifically nursing home residents have been redirected. So what's interesting is that there was a very controversial proposed rule that CMS had, the Medicaid accountability regulation. It was just rescinded a few days ago. And a lot of background there that I have used the links there for you to follow up if this is an area of interest. And then also what I do note in the chapter is that there was this big announcement from Health and Human Services. Well, they recognized this was an area in need, let's just throw money at it. And so they issued nearly $5 billion in nursing home allocation, but they based it all on just an set amount per facility with so much per bed. It wasn't based at all around any other metrics, such as staffing or access to PPE or training or any of the issues that particular homes could be having, which are causing issues and curtailing the spread of the virus. So I bring this up because the answer isn't just to throw money at it without tying it to some type of metrics that are being tracked, and so resources can be more efficiently targeted. The New York example highlights the issue of where there was just a lack of coordinated care between different levels of government. In this case, it would be federal to state to local, and then particularly the actual industry, the nursing home providers. So what happened in New York was Governor Cuomo issued an order in mid-March that was then rescinded in early to mid-May, where basically it put nursing homes in a situation where they really had no way to turn back someone who did test positive for COVID. And then in homes, as we know, it's been incredibly difficult to have a sustainable supply of PPE. At the same time, the governor said, well, it's not our job to ensure that they have adequate PPE. And so rather than address the issues that nursing homes are finding themselves in, which eventually they did by rescinding the order saying they don't have to accept COVID-19 positive residents back into the home. Instead, they passed a liability immunity in New York that specifically protected nursing homes, explicitly protected nursing homes from potential issues of neglect. And also, as part of this great project with the COVID policy playbook, one of our co-editors of the project also has a chapter diving deep into this, chapter 27 on liability and liability shields. And then this is an article we wrote together for the conversation where we go into more detail about what some of these shields look like in terms of a nursing home context. So I provide a number of recommendations in the chapter, and they are broken down the way all the other chapters are broken down, looking at federal, state, and local efforts. But I wanted to just touch on the bigger picture here and how these efforts are somehow being perceived by industry as a type of punishment. But really what we're calling for is more accountability and transparency. And I think it begs to question, if I were a private investor, I would expect to receive regular reports. I would expect that any errors would be corrected so that they wouldn't result in harm or potential lawsuits. I'd want to protect my investment. However, that is not going to be the case when it comes to CMS, specifically Medicaid. And I think we have to question why that is. The other issue I want to touch upon is that this overall harms an industry that's trying to fix its image of being a place where people do want to go to for long-term care. And their actions are essentially punishing the higher performing facilities, which are doing an amazing job during this time of trying to protect staff and residents, of going above and beyond to get PPE, of maybe providing paid sick leave and higher wages to help stop workers having to work in multiple facilities. So it doesn't make sense to say you get this much money based off the number of beds that you have. It makes sense to recognize who are the more poorly performing facilities and the higher performing facilities to even the playing field and overall improve the industry. So I'm happy to announce that the CMS released a report this morning. This is how quickly things are changing. They called for no less than, well, it was as an independent commission, actually, I should clarify, the Coronavirus Commission for Safety and Quality in Nursing Homes, no less than 27 recommendations with quite specific accompanying action steps. And this image does link to the actual report. It's about 186 pages. Just in summary, the report focused on, in many ways, where my area of research does as well, efforts to improve infection prevention and control, safety procedures, and importantly, especially what's happening right now with how long the pandemic's going on, is the quality of life in these facilities and trying to address the social isolation and loneliness that many residents are feeling. So the report goes into a number of recommendations. I highlight 4 here, and essentially it focuses on the areas that I've been emphasizing, where protecting the actual direct care providers, better data, looking at supply issues, and then related to the quality of life, improving the communications. In the chapter, I also mentioned specifically what federal and state level can do, as well as local. And there are some models here for paid sick leave. I believe, I forgot the exact number, but a number of states have legislation worth noting that could be replicated in other states or federally. In Arizona, we have a great paid sick leave law. But then, because of fear or just not knowing that these are potential rights, there's the efforts that can and should take place at the local level with Know Your Rights campaigns to know how to access things like paid sick leave and how it works. So my time is nearly up. I just wanted to note there's a Forbes article that specifically discusses many of the issues that I've highlighted and that were highlighted by the Independent Coronavirus Commission to improve safety and long-term care. And they too also call for better, passionate staff, increasing communications via technology, and most importantly, establishing trust. So that's a great article to read from an industry perspective, where it doesn't need to be us versus them. We need to accomplish this together. And the last thing I want to do is a reminder and a concern that there are arguments out there to defund nursing homes, and that in and of itself needs to be unpacked. And that currently only less than 10% of the population that needs long-term care are providing solely unpaid services. So think about where that work then falls on. Who's taking care of our elderly family members when we can't afford to pay for it? And so it often goes to the home and to the private parties. And so I do discuss how the concerns with that, and in this article here on preparing to age in place and what can be done through Medicaid waivers at the state level. And my last point is that COVID-19 exposed a lot of problems in an area that had chronic issues. And I don't think I want to take it and encourage everyone to not let this move back into the shadows of what's happening to workers in long-term care, along with residents in those facilities. So here is my email address, where please feel free to contact me on email or Twitter. And I'm happy to take questions now. I will stop my screen share. Great.
Hi, Tara, Kayleen here. Right now, I'm not seeing any questions in the chat. So if you have some things that you want to elaborate on or expand on while we wait for some questions to perhaps come in through the chat, feel free to do so.
Great, wonderful. Well, if we were in an actual classroom and there weren't any questions, then I would ask you questions. I would ask if this is surprising to you, what your priorities would be if you notice that, between some of the major missteps I've outlined with staffing, infection control, and emergency planning and accountability, like how to prioritize, where to begin. I've been asked that question before, and I focus on staffing levels, and then along with that, paid sick leave as the priorities. And then I think that also, especially during this time when there's so much hitting our country all at once, federal and state, particularly at the federal and state level, that I think that there is work that can always be done at the local level, especially if you are in a state that already offers paid sick leave. Some of it's just informing workers that they do have access to those rights. And I think in some ways, a lot of the issues I've touched on build really nicely into Rakea's talk, who I know is looking at essential workers through a number of different sectors and their access to benefits. So that might be a nice point to end on if there's no questions.
Actually, I do have a question that's come in. Beyond infection control, what are the risks of physical injury for workers due to lifting and the physical nature of their job, and how that impacts the rate of turnover?
Oh yeah, that's great. That's a great question. Yeah, I think that's true. I think that I think what's tied to it though is the staffing level. So if you have constant labor demand, and you need additional support to help with there's physical demands, then hopefully that could reduce some of the turnover if there was a larger pool in which to pull from. But recognizing that it is a problem is also key to reducing turnover. And I made another point that I should mention. This is a very US-centric presentation, but this issue is happening all over the world. In fact, in England, I looked at their aging and social services sector, and they're experiencing a 30% turnover. They have 100,000 jobs that aren't being filled. So how to correct that? How to make this a profession that people want to go into and be that passionate, dedicated service that the industry wants, that we all want? Well, you look at the wages and the benefits and what that job could entail. Great question.
I do think it amazing that the safety of persons in nursing homes hasn't been considered a public health authority issue by state local government. If meat packing plants are subject to pH measures, then certainly nursing homes should be routinely OSHA monitored.
Yes, they should. And I think that Rakea might be touching on this during her talk. And if not, I do mention it in this chapter and other articles that I've written. What has OSHA been doing in this area? And there have been some pretty shocking studies on the number of complaints they've received and how few of those have been investigated. Part of that comes to funding and enforcement. And I think the other point I want to just build on the question is we're talking about nursing homes, but long-term care is a much bigger umbrella. And if you're a facility that doesn't receive Medicare and Medicaid funding, then you're even more in the shadows and not subject to any kind of real inspection in terms of the kind of quality of care that you're providing.
Another question, what is an ideal staffing ratio?
Oh, there's a lot written about that. I'm happy to forward you some links about it. And you can break it down different ways. The most common way is looking at the number of hours. So for example, the number of hours an aide has to care for a resident. And I think part of that relates to one of the earlier questions regarding the strenuous part of this job. So to look at it hour by hour is helpful to consider in terms of what the optimal staffing ratios can be. There's a really fantastic piece that I'm happy to circulate to everyone where it breaks down optimal staffing levels. And there are some states that have mandated staffing as well. Florida is a state to look at if folks are interested.
Another question for you, is there a way to balance the need for higher wages and benefits and the cost of long-term care to families? Do more governmental resources need to be channeled to this industry in general? Is there another way?
Yeah, that's a great question. In fact, I am working on a piece right now that I'm entitling, Is Long-Term Care Underfunded? Because in looking at the Indiana experience that I noted, that's questionable, right? And technically, and there's many studies that cite this, the average stay across the country in a nursing home is $245 a day. That's over $70,000 a year. For workers that are getting paid $15 an hour. So how are we delivering this care where it's not actually, and it's not actually flowing the way it could flow for optimal patient care and safety? And of course, there are many exceptions to this. I would say the vast majority don't fall into this ballpark, but there are enough that it raises concern that a lot of money is being paid, but it's not necessarily translating into quality and safety care. So it's not just about giving more money. Great questions. Great.
Well, I'm not seeing any more questions in the chat, Tara. So.
Oh, well, I got a nice, oh, that's nice. Okay, I got a nice one regarding the CMS announcement. I don't know about that. That's very kind.
Yeah.
I was really excited to see it though, because actually maybe if I could end on this note for my part of the talk is that part of the reason so many national experts around the country decided to do this project, well, I'll just speak for myself, but I think this is a theme that runs throughout the group, is that we wanted to stop this cycle of forgetfulness, where we see such horrific things in the news and we just become immune or just focus on the next. I've heard it before. And we wanted to actually take real action that we thought we could do better together than independently. And so if any of that led to what CMS did today, then I think that's a great thing, and just how to keep encouraging that past today's conference and past publication of our chapters. Okay. Maybe I'll there. I want to make sure everybody has time, and Raquel has time to present her talk, which I can't wait to listen to.
We do have one. We could try to take one final question. Do you think the ratio of private versus public ownership of nursing facilities impacts the legislation and enforcement of legislation related to quality?
Yes, I do think that plays a role. But you know, it's interesting to compare that, which I note in my chapter. I think 70% of homes are for-profit entities. But some of what's happening in Indiana is not for-profit. It's with the county level hospital system. So I think what really is key is to tie any kind of funding to metrics and improve inspection and oversight so that there's real teeth in the enforcement, but also real resources. I think I think that there is a lot to say for the not-for-profit versus for-profit, but if we had the metrics and oversight, then perhaps some of those variations would be minimized.
So I think we're at time now, if we want to pass it along to our next speaker.
Great. I am just working on sharing my screen, and hopefully you can hear me. Let me do. So thank you for having me. So today I am going to talk a little bit about protecting essential workers during COVID-19. States and localities define essential workers, and the problems that I am discussing are not new. They're ones that we saw during the 2009 H1N1 pandemic, where essential workers who were disproportionately racial and ethnic minorities had increased rates of infections, deaths, and hospitalizations because of their lack of safety protections and lack of paid sick leave. So today I am going to begin by highlighting who is essential worker, some of the laws that we have at the federal level and gaps in them, and some of the gaps in the state government laws, and then provide some solutions, particularly from states. So when we look at essential workers, majority of them are either in the healthcare arena or the food and agricultural industry. A majority of them are women and people of color, and a majority of them live below the poverty line, do not have paid sick leave. And again, just wanting to highlight this note that during 2009 H1N1, there was research that was done to actually show that some of our laws and policies actually increased the rates of infection, but it went beyond that we began to blame some of these workers, particularly immigrant workers, for bringing the disease or spreading the disease, that they were left more susceptible to H1N1 because we did not address housing conditions, particularly for farm workers, and we see that continuing now. These numbers are as of September the 15th. And so you can see the great impact that COVID-19 has had on food and agricultural workers, as well as healthcare professionals. And what I want to highlight, which has not been done that often, is that it's not just the workers, it's their families as well. And so recent studies have shown that Black and Latino children have an increased rate of hospitalization from COVID-19. And some people have argued that is in part because of housing issues, but also because employment conditions for their parents. Their parents are going to work not protected and bringing the disease home to them. So, what powers does the federal government have? And so primarily when we look at these issues, it's the Occupational Safety, Health and Safety Administration in the states that regulate this, particularly the states that have OSHA approved plans. And during COVID-19, we see other people getting involved in the federal government, including the president, the USDA, as well as the Centers for Disease Control and Prevention. I'm going to focus primarily on OSHA and CDC, but feel free to ask me questions about the USDA and the executive order, because I can speak more about that. So when we look at the laws that govern health and safety, we look at particularly that employers are required to provide employees with personal protective equipment and develop a respiratory protection standard. Furthermore, employers have a general duty to provide employees with a place of employment free of recognized hazards. These are great laws. They still have gaps. And in fact, since 2005, OSHA has been working on creating an airborne infectious disease rule. And what that does is that it actually would have required employers to do a worksite hazard assessment to determine airborne disease, airborne infectious disease, and to also adopt specific measures to address any airborne infectious disease spread. The rule was tabled in 2017, but I'm going to talk about it in my solutions about how we can move forward with this rule. But I do want to say that these two current rules, the general duty rule and the personal protective equipment, still provide protection for essential workers. Even though they do, what we have seen is that CDC and OSHA have worked together to issue guidance to employers and employees about how to protect themselves during the COVID-19 outbreak. Unfortunately, there are many problems with the guidance. One, they have been issued late. So when we look at agricultural workers, the report dealing with agricultural workers actually wasn't issued until June, even though there were a number of outbreaks beginning in mid-April. Also, some of the guidances include language that seemingly blames these workers, particularly focusing on their need not to carpool, their need not to live in close residence together, really not understanding the lived experience of these workers. Furthermore, the guidance say that they are not mandatory. They do also include language referring back to the general duty standard and the protective gear standard, but they do not highlight which standards in the guidance are mandatory and which ones are not. So it makes it unclear. Furthermore, none of the guidance actually talk about testing. And as we know, testing is so important to prevent the spread and to also be able to contact trace. And as essential workplaces have become hotspots for COVID-19, this is one of the ways that we need to do better. And I'll talk about that further. When I wrote the chapter, there had not been any fines, but recently OSHA has issued 2 fines, and I have 2 out of 10,000 complaints, and that number is changing daily, so it's already outdated. But 2 major fines for meatpacking plants. You can see that Smithfield was fined almost $13,500, which when you compare it to their net revenue is meaningless. We have about 1,300 workers being infected, 43 hospitalized, and 4 dead. And what I want to do is compare this to California OSHA, which issued its own fine for a meatpacking plant based basically on the same facts, and their fine was $51,000. So you can see how much of a difference it is. Furthermore, when we look at JPS, that was the other fine that was issued, $15,000, and again, they made $52 billion. Not necessarily going to improve this using fines. And just to be clear, the companies and the North American Meat Institute have challenged these findings, saying that they actually were in compliance. And what's interesting is that they claim that they were in compliance with the guidance, which is not mandatory. They don't actually go back to the laws that they were supposed to uphold. So let's talk about state governments. Another issue that I want to raise that was not in my chapter, but I'm just trying to highlight the need to include these employment conditions and safety protections as we begin to issue stay-at-home orders. So I'm in St. Louis, which issued a stay-at-home order in March, where they asked mandatory essential businesses to stay open, but did not require them to adopt policies to stop workplace spread. So it didn't include testing, personal protective equipment, physical barriers. And so we need to think about this as we're moving forward with emergency preparedness laws, that at the time that we're saying stay at home to everybody else, that we provide protections for essential workers to limit their workplace spread. Some other things I want to just highlight very quickly. Some states have moved forward with state business liability laws. I think Ohio is in the process of having their governor sign one. And many of these laws provide protection for state businesses against being sued, but they do not provide protection for essential workers. North Carolina, Utah, and Wyoming provide specifically provide for workers' compensation and mention that in the state business liability laws, but it's not even clear that these workers would qualify because it's not clear whether infection from COVID-19 would be covered. Virginia's law specifically notes this. California, Michigan, and other states have made it easier for workers who get COVID-19 to actually get workers' comp, but again, another gap. So what are some solutions? And I'm going to focus particularly on solutions for health and safety protections. So when we look at agricultural workers, Michigan has been the best. They have ordered a number of emergency orders to try to protect some of these workers, including in the housing. Mandatory testing has been the most recent one, where they require mandatory testing of all workers, protected, of course, but also improving housing, as well as other things. Oregon, they banned the use of bunk beds and guest worker housing. We've seen outbreaks in the housing. And again, going back to the CDC guidance, they focus on the workers as if they are the ones that have authority over the housing. With agricultural workers, these housing places are often also owned by the farm itself. And so if we're going to try to address these issues, we need to focus on the people who have the power to change it, and Oregon has tried to do that. New York has dispatched mobile testing teams, as well as California, to farms so that these workers can get tested. And California and Washington require agricultural employers with more than 500 employees to provide up to 2 weeks of emergency paid sick leave, because as you know, these farm workers are not covered under the CARES Act, particularly because their employer has more than 500 employees. So they're not covered under the paid sick leave. And as I mentioned before, California, Michigan, and Kentucky passed laws to make it easier for workers to get actual workers' comp. So what are some short-term solutions? OSHA should issue an emergency temporary standard based on the 2010 airborne infectious rule that they were working on. And again, that covers hazard assessment, as well as focusing on airborne diseases, mandate testing, and partner with community groups for testing, and really make complaint publicly available and disaggregate by industry. It's very hard to track the hotspots that are happening at meatpacking plants, and so that needs to be made available. They need to issue revised emergency preparedness laws to include employment conditions. And again, as I mentioned, they can issue an emergency temporary standard, but they really need just to finalize the rulemaking for the final rule so it will be in place. And you can see my other solutions there. And I would just say, if you want to learn more about this, these are some articles that I have written with others about these issues. So thank you, and I am ready for questions.
JBS in Nibley, Utah, just this week made a charitable contribution to the city showing how it is helping out and being a good neighbor. This after a COVID-19 outbreak at their plant this summer and some local worker protests. In Utah, the industry can self-fund their workers. FYI, they're saying, in Utah, the industry can self-fund their workers' comp insurance plan, and it's their contracted physicians who determine the work-relatedness of the injury illness. Good luck trying to have a fair decision for the worker.
Yeah, so going back to the JBS, and that is great, but more needs to be done. They made $52 million, and that is just one plant and one particular area. And so what I am arguing is that we need additional support. I would say looking at Tyson, one of the things that they did was to initiate testing immediately. They've opened up health clinics at their facilities. But furthermore, we need paid sick leave and support for these workers. And we also need them to work with the governments to help try to stop the spread and support and protect their workers. So those are the things that I haven't seen. And like I said, even with Tyson, I know they're still having outbreaks, but they are actively doing that and actively moving forward, trying to protect those workers across the country, not just in one particular state. So.
Let's see, I'm not seeing any other questions coming in through the chat other than someone thanking you for the work you do. So nice, wanted to share that with you. I don't know if, Rakaya, if there's other things you want to elaborate on or speak to while we wait to see if we do get some questions come in.
Great, that would be great. And Tara, definitely feel free to jump in. But one thing I didn't highlight in this talk was about home healthcare workers. And they also face some of these gaps. The numbers for healthcare workers who have been infected and died from COVID-19, again, are not disaggregated by sort of industry, hospital, nursing home. But we do see a great impact on home healthcare workers who are not receiving protective gear, who were then actually taking the place of some of the nursing home workers who got sick, who couldn't go in hospitals. And so what I argue is to focus on all of these workers, because they're low income workers, they're not covered by paid sick leave, they're often treated as independent contractors, they haven't necessarily been covered by the coronavirus relief funds. Some states have stepped in. I think it was New Hampshire and Arkansas that stepped in and used some of their CARES funding for these workers to supplement their wages, but most times they're not covered under workers' comp. And so, like I said, I think we really need to change how we do our emergency preparedness laws, that if we are going to label people as essential workers, then we need to provide benefits to them, hazard pay, paid sick leave, workers' comp, things that they'll need to continue to work during an outbreak.
Thank you. Not seeing any additional questions coming up. Here we go. Any comments on restaurant workers who are considered as critical infrastructure workers? So restaurant workers, when there are contacts of positive cases, do not stay home for 14 days because of loss of wages. Any ideas how to address compliance with health department 14-day quarantine?
Yes, so I would say that falls in line with a lot of the other essential workers, that they don't have paid sick leave. And as I mentioned, in 2009, once that H1N1 was happening, lots of researchers showed that there was a link between paid sick leave and increased rates of infection and people actually not staying home because they're in poverty, they can't go without wages. And so one of the things that I mentioned in an author I co-authored with Seema Mohapatra, Professor Mohapatra, was that all essential workers need to have paid sick leave, but we also need to begin to invest in a guaranteed basic income. And I see lots of mayors actually moving forward with this. If a person has a guaranteed basic income, which they started using in Alaska in 1976 and has done well, then that allows for people not to have to make the decision between eating, staying in their homes, feeding their kids, and going to work and spreading the disease. So I think that if we move forward with some of these plans, then that will allow people to be able to stay at home, restaurant workers, people who are independent contractors who are not getting an annual wage unless they go to work.
What do you think is next for liability shield legislation?
What I see next is that a lot of states are moving forward. It's not clear that their changes are that meaningful in terms of lots of the laws are just changing the tort standard between sort of reckless and negligent, but actually it's not clear from court's decisions that that is a meaningful change. I think for me, what I've said in my article is that if we're going to move forward with this business liability laws, then we need to provide support for workers who are continuing to work, right? I think Tara highlighted in her talk about if we're going to work together with nursing homes and federal regulation, it has to be we're working as a team, that we have to provide the money for them. And I think the same is true if we're moving forward with state business liability laws. The reason people sue is because they don't have money for health care. They don't have a guaranteed income, that they're the breadwinner and they're going to lose out if they don't go to work. And so my hope is that if people are moving forward with business liability laws, then they're also expanding workers' comp, hazard pay, and protections for the workers and the people who need to continue to go to work. And also, let's just remember that we have many at-will states. And so part of that is tied up in it as well, is that employers can fire employees at will. And we've seen some cases where they've threatened employees to actually come back to work to not get tested. And so all of that needs to be discussed if we're talking about state liability laws.
Are there current legislative efforts to develop a way to classify workers as essential to provide better protections for them in times of public health emergencies?
I don't know of any. I think that is a great question, and is why I said that we really need to connect our emergency preparedness laws to employment conditions. I am working on an article about that. Don't know if it's going to come out anytime soon because it is such a changing landscape. But I think it is so important that as states begin to issue stay-at-home orders, that they define what they mean by essential workers, the protections for essential workers, and that it should not there should not be a distinction between independent contractors and employees. And furthermore, I do not think it should be a distinction between Americans, immigrants, because many of these essential workers do not have full citizenship status, but they are working and putting their lives at risk. And so they should be covered as well as everybody else.
Well, I'm not seeing any more questions come in. I think we have a little bit of time here. I don't know, Tara and Rakaya, if you have some other things you want to make sure and add with the time left. Otherwise, we can close this session. I'll let each of you speak to that.
So I wanted to ask Tara a quick question, if she wouldn't mind, and then definitely feel free to ask me one. So I've worked in nursing home care, and recently they've begun to highlight the disparities in COVID-19, particularly in nursing homes that are predominantly African American, Latino. What do you think about how we should address those issues?
Yeah, I've been following that as well. I think there's been some really nice coverage on that, particularly in the New York Times. So that's very well highlighted. Also, the LA Times has been covering it very well. And a big part of that is related to PPE at some of those facilities. But another big part of it is just the lack of transparency too with the data in terms of these facilities and how to better track it. Because I think behind a lot of these efforts, we want to go in and say, minorities and women of color have been disproportionately impacted, but if we could show with the evidence how dramatic that is, in my slides in that article I mentioned with the Latina worker in Fairfax County. In that county, it was just to lend some statistics to what you just said. It's 4 times the number of white counterparts to the Latina community, yet they are 3 times more likely to contract COVID, and then of that, this proportion to have a severe reaction to the virus. So it's something that's been ignored, that should not be ignored, and I think that efforts to continue to, I hate to say, go collect more data on something that we already know, but I think it's part of a starting point, and then I think related to that would be funneling greater resources, knowing that community is at higher risk. What are your thoughts?
No, that's great. I agree. I think what has been interesting about this discussion is that initially it just focused on the residents and did so without bringing in sort of Medicaid and class and race and the differences between nursing homes. So I'm excited that they're highlighting it. But as you said, it's get the data and then put into place things we know are working, right? And so increase staff levels, increase wages. I've been working on a wage pass-through review for all 50 states. So we're hoping to get that out just to be able to say, here are some states, they have better and higher wages and supports for these workers, which I think is important.
That's great. Yeah, I know you just mentioned that to me in a different setting, and I'm really excited about it. As you can tell, this is a great group of people that have come together to work on this project. It's been working out very well. But the only thing that I kind of wanted to touch on our remaining time, it is a little bit out of the scope of what we've been talking about, but related to it, is the liability issue, because we are in a unprecedented public health emergency. But as these laws get passed, it's concerning to think what could happen when we're no longer in a state of public health emergency, and how some of these shields are being drafted, where maybe arguably they have the best of intentions to protect employees or workers, or maybe they are not quite up to par. But I think there's a big concern of what could happen when we're no longer in a state of public health emergency and what laws we're passing now. I just like to draw attention to as we start to close.
Yeah, I agree. I think hopefully as we move forward, and I think we both said this, is that if we're passing laws, we need to take into consideration the lessons that we learned before, but these new lessons, right? And so in our emergency preparedness laws, really beginning to think about how can we put powers in to protect those who are most needy in nursing homes and nursing home workers, but making sure that is a part of sort of the powers that the states have and the governors and the departments of public health that are working during this time.
Is there anything else that we can do or add or listen to? We'd be happy to. We're also learning. The changes every day. We develop slides.
So we did have a question come in, and I think we have time for this. Is there an example of essential workers who organize in order to address their issues and demand better legislation?
Yes, there are a number of groups that have been working on this. A lot of meat packing and meat and poultry processing workers have organized and actually got increases in wages, some hazard benefits. See the same thing happening in California, where some of the farm workers have been, I wouldn't say striking, but organizing to do that. Many of the unions have been working to push OSHA. And so there was one lawsuit to try to get them to push and issue an emergency temporary standard. And that was the Nursing Association, meat processing, many of the major unions doing that. So they are working to get better conditions, but I think that they shouldn't have to. And we provided some solutions for governments. I think, and some governments are being proactive, like Michigan, California, Washington. And so hopefully other states, other communities will use those examples.
If I could just add and build on that, there is a role for universities, particularly in law and the clinics that we offer at our law schools. We offer a worker rights clinic at Arizona Law, and I know there's other versions of that around the country. So, I mean, there's a way that we can also support these efforts and not expect it to be completely from the ground up, but with larger resources at universities and groups like Change Lab Solutions can help support these efforts too. And it's a great question, and something where we're in such gridlock right now and difficult to get anything through. How can we locally organize?
Well, I believe with that, we're at the end of the session. I want to thank you both for an incredible session today. And I want to encourage all of our attendees to please let us know what you thought of today's session by taking the survey. The button's located under the video feed. Thank you for attending the summit, and I hope you have a great rest of your day.
Thank you, everyone.